Welcome to this explainer. Today, we're stepping right into the high-stakes, thrilling, and frankly, often invisible world of disease detectives. We're going to uncover the science of epidemiology. This is that fascinating space where clinical medical knowledge meets rigorous, boots-on-the-ground investigative work. Just imagine a scenario for a second. A mysterious illness starts sweeping through a town. There are no fingerprints, no obvious suspects, just a rising count of sick people. So, how do we stop it?
Think about it this way. If a doctor treats an individual patient, who treats an entire population? When a health threat scales way up, from a single hospital bed to thousands of people across a city or even the entire globe, the whole approach has to change completely. We're talking about massive, large-scale public health investigations here, and it requires a very specific type of expert to untangle that messy web of transmission.
Okay, let's dive into this. Here is our syllabus for today's detective training. First, we'll officially meet the disease detectives. Then we'll dissect the anatomy of an outbreak and trace the chain of infection. After that, we'll investigate the scene. And finally, learn how to read the vital evidence. Let's kick things off with Section 1. Meet the disease detectives.
At its core, epidemiology is all about studying the distribution and the determinants of health in specific populations. Now, what's really interesting here is the stark contrast to clinical medicine. While clinical medicine focuses on treating a single individual case, a patient seeking treatment in a doctor's office, epidemiology zeroes in on an entire defined population at risk. The epidemiologist actually goes out into the community to survey both the sick and the healthy, looking for overarching patterns. They really want to know how often a disease occurs, where it's happening, who exactly it's affecting, and ultimately why.
To really hammer home this contrast, clinical medicine diagnoses patients to cure their illness. Simply put, doctors treat the victim. Epidemiology, on the other hand, diagnoses entire communities to control transmission. The epidemiologist is hunting the pathogen. Their main objective isn't just to cure the individual, but to identify the source of the infection, uncover its exact mode of transmission, and put preventative measures in place to make absolutely sure the wider public is protected from future harm.
Moving right along to Section 2, Anatomy of an Outbreak. So, to catch a criminal, you've got to understand the nature of the crime, right? We start at the baseline, which is an endemic. As you likely know, in public health, this is the expected, constant presence of a disease within a given geographic area. Think of it as the background noise of public health. It's an infection that just maintains itself in a population without needing any external inputs. This is the steady, everyday state that we are constantly monitoring.
But then, things can escalate into an epidemic. An epidemic is basically the public health alarm bell. It's a sudden, dangerous spike above that expected baseline, and it signals a critical shift in the environment or in host vulnerability. It tells us that the existing fragile balance between the agent causing the disease, the host, and the environment has been broken. That unusual occurrence of disease, which is clearly in excess of normal frequency, demands an immediate, highly targeted investigation. So the crucial point is understanding what happens when that alarm bell rings worldwide. That's a pandemic. A pandemic is an epidemic that has completely shattered geographic boundaries, spreading over a massive area, like a whole continent or literally the entire globe, and affecting a huge proportion of the population. The influenza pandemic of 1918 is a classic, though absolutely devastating, historical example of a pathogen that scaled its threat globally, and it fundamentally altered human history in the process.
All right, Section 3, the chain of infection.
Every single infectious disease out there, from the seasonal flu to cholera, relies on a highly specific sequence to survive and spread. It's basically a biological chain reaction, and this brilliantly illustrates those three vital links. It always starts with a source or reservoir. That's the natural habitat where the organism lives and multiplies. That could be a human carrier, an animal, or even just contaminated soil. From there, the pathogen needs a mode of transmission to escape and travel. And finally, of course, it has to find a susceptible host to infect so it can continue its life cycle. That middle link, the escape route, is particularly fascinating. Pathogens can be transmitted directly through physical skin-to-skin contact or by infected droplets from a sneeze or cough, but they can also travel indirectly, and this is where it gets incredibly complex. They can be vehicle-borne, hitching a ride in contaminated food or water. They can be vector-borne, using living carriers like mosquitoes or fleas to bypass our natural defenses. Or they can be airborne, literally floating invisibly on tiny droplet nuclei for hours on end. In the field, epidemiologists often shorthand these sneaky indirect routes as the 5 Fs: flies, fingers, fomites, food, and fluid. Now for Section 4, investigating the crime scene.
When an outbreak is officially detected, epidemiologists put on their boots and head straight into the field. Let's see how this highly structured response builds. First things first, they absolutely must verify the diagnosis. Public reports can sometimes be a bit spurious or misinterpreted, so detectives confirm the disease right on the spot. Once that's verified, they define the population at risk, maybe by mapping out a neighborhood or running a rapid census. Then, they actively hunt for all cases, interviewing people with detailed epidemiological case sheets to track every single symptom and interaction. With all that data, they analyze the patterns, formulate a solid hypothesis about the source, and finally they implement control measures to stop the spread cold. To make sense of all that raw, frankly chaotic data gathered from patient interviews, disease detectives organize their evidence around three classic parameters: time, place, and person. By plotting the time of onset, they build an epidemic curve to figure out if it's a single common source exposure or a propagated person-to-person spread. By plotting geographic locations on a spot map, they uncover visual clusters. Actually, this is exactly what the pioneering physician John Snow did way back in the 1850s when he mapped cholera deaths in London, tracing the entire devastating outbreak to just one contaminated water pump on Broad Street. And finally, by analyzing the person, their age, sex, and occupation, investigators can pinpoint exactly who is the most vulnerable.
And that brings us to our final section, Section 5, Reading the Evidence.
So, visualizing the data is really only half the battle. To actually prove their case and predict the pathogen's next move, detectives have to crunch the numbers. The most basic forensic tool in public health is a rate. A rate measures the occurrence of a particular event in a population over a very specific time period. It essentially calculates the actual dynamic risk of developing a condition. For example, a death rate takes the number of deaths in 1 year and divides it by the mid-year population. This standardizes the number, allowing us to track risk accurately over time. A ratio, on the other hand, gives us perspective. By comparing two distinct, sometimes entirely separate quantities, like the number of available hospital beds compared to the wider population, it exposes just how stretched our resources might be during a sudden crisis. It simply expresses a relation in size between two random quantities, where the numerator is not necessarily a component of the denominator. It's essentially a quick snapshot of capacity versus demand. Now, when calculating a proportion, we are looking at a part divided by the whole. Because of this, it is always expressed as a percentage. In an example like tracking scabies, we're simply isolating the infected children in the numerator from the total village population in the denominator to gauge the immediate penetration of the disease. It provides a crystal clear, instant metric of how much of that specific population is currently affected. Finally, when it comes to measuring the actual sickness or morbidity in a population, epidemiologists rely heavily on two vital metrics: incidence and prevalence. Incidence is like a radar, specifically looking for new blips. It measures only the new cases occurring in a population during a specific time frame, showing us the current active risk of contracting the disease right now. Prevalence, however, is a snapshot of the total disease load. It counts all the existing cases at a given time, regardless of when they actually started. Together, these two metrics tell us not just how fast a disease is spreading, but how heavy the long-term burden is going to be on the community's healthcare system.
By truly understanding rates, ratios, incidences, and prevalence, we transform the sheer chaos of a health crisis into actionable, life-saving data. We find the source, we uncover the transmission route, and we break that chain of infection. So after walking through the anatomy of epidemics and learning the forensic tools of the trade, consider this: are you ready to view the next outbreak through the eyes of an epidemiologist? The next time you hear about a disease in the news, look for those patterns of time, place, and person, and remember the massive, incredibly complex detective work happening right behind the scenes. Thanks so much for joining me on this explainer, and keep your curiosity sharp.